evaluated by the local health officials were found not.
Now going to leave this recorded discussion to bring you live coverage of the hearing on severe acute respiratory syndrome, SARS. This is live from the Senate Health, Education, and Labor Committee meeting in the Dirksen building on Capitol Hill.
Threat of SARS, the virus which or sickness which has obviously gained international attention and represents a significant health concern for all of us. The SARS disease has spread across the world, although it is centered obviously in China. But I noted in the most recent statistical analysis that after China, if you consider Hong Kong to be part of China, which it is, Canada becomes the nation with the second largest known cases of SARS. It obviously raises huge issues for us as a nation and for the world as a community. Issues of how we contain it, issues of how we address it and hopefully find a cure for it, issues of how we identify it to begin with, of course. The health community has worked extremely aggressively on the international and national level, and I certainly want to congratulate the World Health Organization for their superb effort at trying to bring coherence to how we address this health threat. And we will have with us today, addressing us from Geneva, Dr. Heymann, who is the head of the World Health Organization in this area. We also have joining us today the head of CDC, Dr. Julia Gerberding, who's done an exceptional job in a lot of different areas, but is obviously leading the fight in this area, along with Dr. Fauci, who is the leader at NIH in the area of communicable diseases, been before the committee on numerous occasions, and is also coordinating and leading this aggressive effort to try to get our hands around and arms around this significant health threat to not only our country but to the world. These two agencies, NIH and CDC, are the premier agencies not only in our country but in the world in the area of combating communicable diseases, and therefore their leadership is important not only to us here in the United States but to the world community as a whole as we address the SARS threat. So it's a pleasure to have them here today to testify before us. They're the ones we want to hear from. We'll limit opening statements to myself and Senator Kennedy, and I'd yield to Senator Kennedy at this time.
Thank you. Thank you very much, Senator Gregg, for calling this hearing, which is enormously important and be incredibly significant to our fellow citizens here in this country and people around the world. And I join you in welcoming Dr. Gerberding and Dr. Fauci, who are two very special leaders, not only in understanding this challenge, but in so many other health-related areas. It's less than a month since the first report surfaced of this dangerous new disease, and it's already spread around the globe with thousands of cases and dozens of deaths. And we live in a time when deadly disease can leap oceans and travel the globe in a matter of hours, as fast as an airline passenger can fly. And it's spread easily from person to person, and there is no vaccine or miracle cure. The evidence indicates that it's caused by a virus. Treatments based on how we treat flu-like disease are all we can provide so far. The best weapons in combating this deadly disease are the skill of our healthcare workers and the ingenuity of our scientists. I had the opportunity to hear from some of the nation's best doctors and scientists at a forum on SARS on Friday in Boston. We drew on experts from clinical medicine, public health, and basic science to hear the best insights and recommendations on how to respond to this extraordinary new health challenge. Even without a single death so far in the United States, the impact of SARS has been significant. I heard on Friday that restaurant bookings at Boston's Chinatown have dropped by over 60% because of possible fears of outbreak there. The state health department is receiving over 200 calls a day about the disease. In a recent town meeting held in the Boston Department of Public Health drew over 100 people last week when they were expecting 15 or 25, all anxious to receive the latest information. Congress has provided a down payment on the resources that will be needed to fight this epidemic. Last week, the Senate accepted an amendment that Senator Clinton, Senator Murkowski, and I offered that will add $16 million to the CDC, the Centers for Disease Control budget, to fight SARS. And I understand that the CDC has assigned over 300 personnel to this outbreak, so more resources will clearly be needed in the near future. Health departments across the country are already reeling under the impact of budget cuts and the burden of implementing the smallpox vaccination plan, and this new epidemic will strain their capacities yet further. So SARS is also a wake-up call for another reason. There's no indication it began as a terrorist attack, but what if it had? A virus can be just as destructive as a bomb or a missile. Homeland security means protecting our country against health threats as vigorously as we protect them against military threats. Yet today we are already stretched to the limit in protecting the country against bioterrorism. Obviously, we must provide the resources needed to meet both the man-made threat of terrorism and the natural threat of SARS. Senator Frist and I held hearings in the past on possible threats from bioterrorism. Bioterror provisions in the bill enacted after 9/11 were a key turning point in preparing a response. We've been worried about the other germ threats as well, such as West Nile virus. We're concerned about the widespread routine use of antibiotics in agriculture for animal feed and the danger that germs will mutate into forms that are resistant to all forms of antibiotics. Clearly, we need to strengthen our defenses against these perils. Health departments and hospitals across the nation are taking needed steps to improve preparedness against these modern disease threats. At a time like this, it makes no sense for either Congress or the states to be cutting reimbursements to public health agencies and hospitals struggling to face these challenges. Today we'll hear about SARS from three of our best experts. Dr. Gerberding has led the CDC through some of the greatest challenges in its history. She has helped protect the nation against the deliberate use of infectious disease as a weapon, and now the talents of CDC's extraordinary doctors are being mobilized against SARS. One of the points made at a forum on Friday was the extraordinary respect by public health professionals for the job that CDC has done in responding so far. We're also pleased that Dr. Fauci is here. He and the NIH have given extraordinary service to the nation in their work on AIDS and many other infectious diseases, and I commend him for his leadership. And we're also honored to have David Heymann for the World Health Organization joining us by video conference, and he is at the forefront of the emergency international efforts to combat SARS. And I look forward very much to the testimony of these impressive witnesses at this extremely important hearing. I thank you, Mr. Chairman.
Thank you, Senator Kennedy, and we'll begin. The procedure we're going to follow is to hear from Dr. Gerberding, then Dr. Fauci, and then Dr. Heymann in Geneva, who we very much appreciate joining us by satellite. So if we could start with you, Dr. Gerberding.
Senator Gregg, Senator Kennedy, we really appreciate this opportunity to appear here today. I think it's so important to get this kind of information out to the public and to Congress as it evolves. So I really am very, very grateful for this chance. As you know, in November, mysterious reports of a severe respiratory illness emerged from Guangdong province in China, and by February, there were well-documented reports of some cases of a new pneumonia in Hong Kong. By March, WHO recognized that this disease was spreading rapidly in Hong Kong and in Hanoi, and issued a global health alert on March 12th. On March 14th, CDC activated its emergency response center to deal with what we recognize would likely be a complicated multi-jurisdictional international outbreak investigation. And since that time, we've been mobilizing our full emergency response capacity, our communications capacity, as well as our laboratory science capacity to support the public health response. What you can see on this graphic is that this has very quickly become an international epidemic, starting here in Asia, but then with foci of cases across the entire globe. We today are aware of 2,301 international cases, plus an additional 148 cases here in the United States involving 30 states. So we are continuing to aggressively evaluate suspected cases in the United States. The case definition for SARS is non-specific, basically a traveler to an affected area or someone who's had contact with the SARS patient who develops a fever and respiratory symptoms. Many of these people have SARS, some have the other common respiratory illnesses. And so one of our biggest challenges right now, while we're trying to contain spread through public health and infection control measures, is to get a diagnostic test as quickly as we can. Let me show you just in a little more detail the situation in the United States, because I think it helps understand how this disease is being transmitted. On the next graphic, I have what we call the epi curve, or the epidemiologic curve, and you can see that over time, beginning in early February and then progressing to where we are at the end of March, there are increasing numbers of cases being detected in the United States. But all of the cases in blue are cases in people who've traveled to Asia, Hong Kong, Hanoi, Singapore, areas where this disease is spreading. The green bars right here represent contacts of these case patients in the United States. There are only 5 individuals right now who have SARS as a consequence of household exposure in this country. And then here there are 2 healthcare workers who acquired SARS, or at least acquired a disease consistent with SARS from a case patient. And recently, over the weekend, we have a 3rd healthcare worker who's been added to the suspected case list. This is a pattern that's very different from what we are seeing in other parts of the world, probably because we were able to get aware of this and implement the appropriate hospital isolation precautions very quickly to protect healthcare workers, and then the home infection control precautions to protect household contacts. But we're also concerned that there are some people, the so-called hyper transmitters or super spreaders, that we've heard it in the press. Some individuals may be especially infectious or especially contagious. And so there is always the chance that we'll be seeing a further spread of the infection here in this country, just as it's been observed in Canada and elsewhere in the world. On my final graphic, I have a picture of the virus that we believe is the leading hypothesis as the cause of this illness. This is a coronavirus. It's called corona because in this section it looks like a crown, with the spokes of the crown coming out from the circular virus. Coronaviruses cause diseases in a whole array of animal and bird species, including cats, dogs, pigs, cattle, and so on and so forth. They are an important veterinary pathogen, and there are many vaccine products that have been created to try to protect animals from coronavirus with various degrees of success, sometimes not all that successfully. But we know a great deal about coronaviruses as a family. The laboratories at CDC in Hong Kong first isolated coronavirus from early patients, and since that time, at least 8 other laboratories have found evidence of coronavirus infection in the patients. What's important to us is, first of all, this is a new coronavirus. It's not like any others that we have become aware of, and we expect that our laboratory and other labs this week will likely have the entire genome of this virus sequence. It's one of the largest viral genomes that exist, and it's a single strand of RNA, which means it's very unfaithful as it reproduces itself, so it can evolve over time, and that's why there are so many different species of this virus in animals and so forth. We do have tests now that can detect evidence of coronavirus infection. We actually have 3 tests that we're using to look at the case patients. 2 of them are based on antibodies that develop in patients over time, and one of them is a PCR test that can find pieces of the virus genome in specimens from the case patients. So as we evolve the reagents and get these tests out into the health community, we'll better understand the spread, but we'll also be able to help in individual cases identify patients. The last thing I wanted to mention is the issue of treatment. This is a new virus, and we don't have things on the shelf that we know are effective against coronavirus. Many clinicians around the world have been using ribavirin, which is a drug for other kinds of virus infection, and we just don't have the right kind of clinical information to make any judgment about whether it's effective or not, although I think increasingly we're a little pessimistic that it's actually going to be a useful drug. But we are working with the U.S. Army Medical Institute of Infectious Disease Research to screen drug compounds, and if anything tests positive, we'll be able to go from there. I think Dr. Fauci is going to give a little more information on drug screening and what we might see in the future for a vaccine. So to summarize all of this, I would say that what we have here is an epidemic of new virus or some virus that's causing problems in virtually every corner of the globe. We are controlling it primarily by identifying exposed and case patients and implementing public health measures to prevent spread. We don't know where this is going to go. If we're lucky, it will have a seasonal pattern and it will wane over the summer months, or maybe what we're seeing in the early stages is this large increase will level off. But we're taking it very seriously. We have to be prepared for this to continue to spread, and we are doing everything we can across the public health system, the scientific system, as well as the research system to be out in front of it. Thank you.
Thank you, Doctor. And Dr. Fauci?
Thank you very much, Chairman Gregg, Senator Kennedy, Senator Dodd. As Dr. Gerberding mentioned, I truly appreciate the opportunity to appear before this committee that has been in the past so helpful to us in our own endeavors over the past several years in emerging and re-emerging diseases, and most recently in the arena of biodefense against weapons of bioterrorism. I want to start off by echoing the point that Senators Gregg and Kennedy made regarding the job that the Centers for Disease Control and Prevention and the World Health Organization have done on this. As a research scientist involved in infectious diseases, the degree of competence and collaboration that the Centers for Disease Control and Prevention have manifested in this is really quite extraordinary, and I wanted to take this opportunity to publicly thank Dr. Gerberding and her colleagues at the CDC for the most extraordinary job that they've done. This is a poster, sir, that I have shown in this room on more than one occasion, but I've added something to it, and it has been some of the hearings that we have had in the past on the whole concept of emerging and re-emerging infectious diseases, which are a threat to our species essentially from the beginning of mankind and indefinitely. When we talk about a re-emerging disease, we talk about something that was a disease in a place or in a form that we had not seen before. A good example of one that we've recently encountered is West Nile virus, which is not a new virus at all, but it is now in a different place, namely in the United States, when in fact it had not been before 1999. An emerging infection is one that is new to our species. A good example of that is HIV/AIDS. Now, if you look at this rather complicated slide of a number of emerging and re-emerging diseases, some of them, every once in a while, evolve into a major public health threat, and others, relatively speaking, are little blips on the radar screen in that they stay confined to the time and the place when they initially emerge. With SARS, we know for sure that we're not dealing with just a blip on the radar screen, but as Dr. Gerberding says, we're not really sure where it's going to go because we are truly in the middle of the evolution of an epidemic. We just don't know whether it's going to peak and then go down, or whether it will go down and then come back up at a different season. And for that reason, we have to take this very, very seriously. Dr. Gerberding mentioned that the prevailing evidence, and it gets stronger and stronger each day, is that we're dealing with the coronavirus. And she made some important points about it, so I won't spend much time on it to say, except that since the coronaviruses as a group are a known group of virus, there has been research going on for years in a number of laboratories, also several laboratories in the extramural and intramural program that have been supported by the National Institutes of Health. And as Dr. Gerberding mentioned, it's both a veterinary and a human infection. There are no adequate therapies and no adequate vaccines, but we do have people who have been working on them for several years. So what I'd like to do is just spend a minute or so very briefly touching some of the areas of research. Dr. Gerberding mentioned the surveillance and the epidemiology. We have an NIH-funded investigators who are actually very closely aligned in Hong Kong with looking at the evolution fundamentally of new influenza viruses from animals, from pigs and fowl. And those individuals are now currently collaborating with the Hong Kong group and have actually isolated a coronavirus in confirmation of the CDC's activity. When you talk about basic research, one of the things that's interesting about this is that coronavirus is generally a fastidious virus that's difficult to grow in culture. We have found, with the help of the CDC, who have given us the material that they have, that this virus grows quite well on certain cell lines, such as a Vero cell line, which is a monkey-derived line. Now, the reason that is in some respects in the sober situation that we have now, good news is because it would have been very difficult if we could not grow the microbe. Assuming this is the microbe, which we feel strongly that it is, this is a situation where we now have the microbe in hand and we can actually start producing it for the purpose of testing it against antivirals. And as I'll get to in a second, take a look at the situation vis-a-vis vaccines. The pathogenesis means how does this microbe cause its pathological effect, the genesis of the pathology. And that's what we're going to be studying very intensively now that we have the virus, because we're not sure at this point whether it's the virus itself that's causing all the damage in the lungs of the individuals, or if it's the virus together with what would be a normal immune response, but in some diseases, the immune response itself causes damage. We have certain infections in which a certain type of an immune response can actually make the pathological effect worse. We see that in some cases of respiratory syncytial virus, in some cases of measles. So it's important for us to nail down the pathogenesis. The big item is vaccines. Right now, again, fortunately, we have the virus growing in culture. So the stepwise approach to developing a vaccine is the easiest thing to do quickly is to take the virus, kill it, and have what's called an inactivated virus. That research is going on as we speak right now at the NIH in Bethesda, as well as in other areas of the country and the world. The first thing you do is you grow it and you determine, in fact, if you can get an animal model in a mouse or in a monkey. The fact that it grows in monkey cells gives us optimism, though we haven't proven it yet, that a primate model might be a good model to test a vaccine. The other thing you do is you take the sera from people who are recovering or who have recovered and find out once you once you infect an animal, if the sera can block the disease in that animal, then that's a pretty good indication that a vaccine might work. And these are all the steps that are rapidly going on. Dr. Gerberding mentioned the drug screening development program. We're collaborating with the CDC and US AMRID in that regard. We're looking at panels of drugs that already exist. You might recall that when we developed our first drug against HIV, it was in a screening program of a drug that came off the shelf. The very first drug was AZT. You remember very well, Senator Kennedy, we discussed that many, many years ago at this panel, in which we actually had a drug that came off the shelf. There are other drugs like interferon that we know work against certain viral diseases. We use it in hepatitis C. We're going to be testing it in this particular situation. Immune-based therapy, namely, when someone recovers, can you isolate from their plasma the immunoglobulins that are directed against the virus and therefore perhaps use that in a way for therapy? I already mentioned animal models. And finally, clinical research at the clinical center in Bethesda. We will be setting up protocols in collaboration with the CDC and other of our colleagues that if we have cases that are actually in the area that we can look at, we'd be able to execute some of the protocols, be they immune-based therapy, be they treatment protocols, or be they understanding the pathogenesis. And so you see, although this is an extraordinary challenge, and we can't give any guarantee at this time, the mobilization of the research endeavor together with the public health endeavors of the CDC has been extraordinary. So in closing, Dr. Gerberding has shown how the public health system in a very, very difficult situation is in fact working. What I have shown you is a very brief example of how the investments that we've made over many years in the arena of emerging and re-emerging diseases can and will be rapidly applied to address the situation of SARS, as well as the inevitable situations that we will surely face in the future with other naturally occurring or deliberately released pathogens. Thank you very much. We'll be happy to answer any questions.
Thank you, Dr. Fauci. And now we'll turn to Dr. David Heymann, who is in Geneva. He is the Director of Communicable Diseases with the World Health Organization. And I want to again thank the World Health Organization for the extraordinary job they've done in focusing world attention on this and trying to coordinate an international response. And hopefully this technology will also work. And we look forward to hearing your thoughts, Doctor.
Thank you, Mr. Chairman. It's a privilege to speak with you today and to speak with our valuable collaborators from CDC and NIH. As you surely know, WHO depends greatly on the United States and its facilities, and especially on CDC and NIH to support our activities worldwide. WHO implements the international health regulations, which are a set of norms and standards set out for airports, seaports, and other ports entering countries, and also requires reporting of infectious diseases. These regulations are adhered to by our 192 member countries. Over the past 5 years, WHO has been revising these regulations to be more in touch with the 21st century. And the outbreak of SARS has given us the unexpected opportunity to try out the operational procedures which we've been developing as we revise the international health regulations. And it's under the authority of the international health regulations that on February 10th, WHO, through its office in Beijing, was working with the Chinese government to learn more about an epidemic in Guangdong of acute respiratory infection that had begun on the 16th of November. On the 17th of February, WHO then spread its team into Hong Kong as well, because at that time there were 2 persons who had the bird flu or AH5N1 virus identified from them. So there was a heightened concern on respiratory diseases in China and Hong Kong at the period when on the 28th of February in Vietnam there was a case of a very atypical pneumonia which rapidly progressed to respiratory failure and which by 5 days later had infected 22 health workers in that hospital. At the same time, we learned that there were outbreaks of a similar disease going on in Hong Kong. It was not clear yet whether this disease was influenza or whether it was some other disease. But on the 12th of March, because this disease was a very serious disease involving, for the most part at that time, health workers, we went out with a global alert, as Dr. Gerberding has said, notifying all of our countries in the world that there was a new unrecognized disease in Asia. After the 12th of March, we were working with countries, and on the 14th of March, 2 days later, we had a report from Canada that they had put their health authorities on alert that there was a similar disease occurring in Canada. And on the 15th of March at 2 a.m. in the morning, we received a phone call from Singapore indicating that a physician who had been attending a congress in New York was on his way back to Singapore with a similar disease. We'd had that plane diverted to Frankfurt, and the patient was isolated in Frankfurt. But on the 15th morning here in Geneva, we had several concerns, and I'll just list those concerns for you. First of all, the cause of this respiratory syndrome was at that point unknown. We knew that it was very important to health workers because health workers were the major people at this time who had been infected. About 90% of all cases were in health workers. And we knew that antibiotics and antiviral drugs that we're using did not seem to be having effect. At the same time, the disease was spreading international. It had gone to Canada, it had gone to New York, and it was now in Frankfurt as well. And it was a serious disease which spread very rapidly in some instances to respiratory or breathing failure, requiring respirators. And finally, at that point in time, not knowing what the disease is, we understood that it was best or easiest transmitted from person to person by close contact. And we thought that possibly by raising a global alert, in addition to preventing many health workers from becoming infected, we might be able to contain this disease as it was starting up so that it would not become still another endemic disease, a disease such as tuberculosis or malaria, which affects human populations. We continued with our global surveillance and response, tracking the disease around the world with our colleagues in many institutions, including CDC. And on the 27th of March, it came to our attention that there had been passengers on international flights who were sitting adjacent to persons who now we knew had SARS, who had become infected on those planes. So on that date, we recommended that countries which had this disease begin screening the passengers leaving to make sure that if there were passengers with this disease, they would not fly at that time, but rather be referred to health workers. Many countries, such as Canada and Hong Kong and Singapore, those countries where there was community-level transmission in the greatest epidemics, did institute these practices. On the 7th of April, though, we looked again through our figures, and we found on that date two different events. We found that passengers continued to travel out of Hong Kong with the disease, and in fact 9 passengers had traveled to areas in Taiwan, in Singapore, and in other countries with the disease after the 15th of March, when we had put out our alert. So passengers were still traveling, and at the same time, on that same date, we understood that other issues were occurring in Hong Kong, that this disease appeared not to be close contact to person only, but had somehow been able to spread from one person to another through an object or something in the environment in an apartment complex in Hong Kong. With these two understandings, we made a recommendation that passengers postpone voluntarily travel to Hong Kong and also to China, because at that point we did not clearly understand what was going on in Guangdong in China. On the 17th of March, we began 3 collaborating groups: laboratories, epidemiologists, those people who study infectious diseases, and clinicians to better understand the disease. And Dr. Gerberding has given a good summary of what we understand from those groups. One issue was a very important issue to us, and that was China. And as you know, China had not been open with the information about the disease, as open as we had hoped, despite our working intensively with them. But gradually, over the period from 10th February until the present, they have become a full global partner in this outbreak investigation. We now have a team which is in Guangdong province. We're working in other cities in China to understand the issue. Now, the issue that we understand in China was that health has been delegated to provincial levels, and the national government had no authority over those provincial governments as far as infectious diseases were concerned. That has changed 1 week ago, when China has instituted a national reporting system for SARS and some other infectious diseases, requiring provinces to report this information to Beijing. And this information is now also being made available to us. So we see that this global response, although it's been long in coming, has included a partner which was reticent at the start. We hope that as we continue this response, and afterwards as we continue the revision of the international health regulations, we will be able to require that all countries work closely when there is a disease of international importance. The response has been remarkable to date. Laboratories have collaborated, sharing information that maybe 5 years ago they would have kept to themselves so they could publish it first, and we see that the world has responded the way we had hoped it would. Thank you, Mr. Chairman.
Thank you, Doctor. I appreciate that excellent overview. I appreciate the excellent overview of all 3 of our superb witnesses here today. If I could direct my first question to Dr. Heymann, can you give us a sense of what you're projecting as the spread of this disease, number 1, and number 2, do you feel that the countries which have the most severe outbreak of it, specifically China, and you alluded to this, presently are able to control its spread within their borders and the communication of it outside of their borders?
Let me start with Vietnam, which called for help early. Vietnam called for an international team very early. The epidemic was well contained, and there will be a few cases, but we believe it's contained in that area. In Guangdong, in China, the epidemic, we believe, has been going on from 16th of November, and our team has information that it continues in the Guangdong province, and we also have information that other provinces are affected. China will begin to work with WHO. We don't know the extent to which they will work with us, but on that WHO team are the best experts in the world, coming from CDC, coming from Australia, coming from Japan, and many other countries. We will be talking with our WHO office in Beijing tomorrow and hope that we will have from them an idea of how much more reinforcement we can send in. And we believe that we will have the opportunity to help the Chinese contain the outbreak there. Hong Kong is a concern. We will be reinforcing our team in Hong Kong at their request today also. So the outbreaks are being contained, we hope that we will be able to work closely with China to contain what's been an ongoing and long-term epidemic in China. And we believe that we will be able to contain at least some of the epidemics. As far as what will happen internationally, I don't believe anyone can tell you, Mr. Chairman, what will happen. We're all waiting to see. We're all doing our best to make sure that it is contained as it spreads.
What are
Thank
you
you.
recommending that countries do relative to movement of citizens across borders, especially relative to nations which have a high degree of infection?
The decision of what a country will recommend must be based on many things. Number one, it's based on a WHO recommendation. And we've recommended now that travelers avoid Hong Kong and Guangdong because of the spread of the disease in those areas. But national governments must also consider insurance, the possibility of medevacing their citizens, and other issues when they make their recommendations. So we expect that countries will make recommendations which are different from ours because of their understanding of what they can do for their citizens in those countries should they become sick. So our recommendations are for two areas, Hong Kong and Singapore. And Guangdong. We understand that the U.S. and other countries have recommendations for other countries as well, and they fit in with our guidelines.
Now we've seen these surgical masks being worn throughout airports in China. I would like anybody on our panel to describe to us what is the use for these? Do they have a practical, positive medical use or not?
Maybe I can put some perspective on the mask issue. The most important use of masks is for healthcare workers in healthcare settings to protect themselves from case patients. And the healthcare workers are expected to use a very specific kind of mask that has a better filtration than the one you've just held up. It's called an N95 respirator, and is the kind of mask that we would use for tuberculosis as part of airborne precautions in healthcare settings. The surgical masks that you've raised are useful in keeping large droplets from disseminating from the mouth or nose of somebody who's sick. And so we recommend that if a SARS patient is in their home, then if they can comfortably wear such a mask, it will help prevent spread to their household contacts. If the patient can't wear the mask, then we're advising the household contacts to wear the mask so that they don't get exposed to these droplets that come out when you cough or sneeze. Beyond that, we are not recommending masks for anyone at this point in time, but we understand that people are nervous and that in parts of the world where this really is spreading in communities, a lot of people are using them as sort of a just-in-case scenario.
You've identified 148 cases in the United States, or potential cases.
Potential
cases. Canada, as I understand it, is the second largest number of cases in the world after China and Hong Kong. How should we in the Western Hemisphere be dealing with this? And are we dealing with it adequately? What should average citizens be doing? And is there something else that our health community should be doing?
The most important step is identifying somebody who may have the condition. And so I think we have been making extraordinary efforts to alert passengers arriving on planes from areas where this disease is being transmitted. And overall, we have actually distributed about 300,000 of those. You have a little yellow card in front of you, which is an example of a travel alert.
We'll have it in front of us soon.
Okay, you will have a little yellow card in front of you. We've translated this into several languages, and they are being distributed at the ports of entry from flights coming directly from the affected countries in Asia, but also people who are traveling indirectly via other ports of entry. This is an effort to remind people that they've been in an area where SARS is present, and if they develop a fever or respiratory illness within 10 days after their last exposure, they should contact a health authority and let them know that they could be at risk, so that arrangements can be made for them to come in and be in the proper infection control precautions when they're evaluated. The second most important thing is that when a SARS patient comes into contact with the healthcare system, that they are immediately put in the appropriate protective environment for isolation purposes so that it doesn't spread to healthcare personnel and others.
My last question before I turn to Senator Kennedy, I wanted to ask Dr. Heymann, is there anything else that the United States, either the government or our health professionals, should be doing to assist the World Health Organization as it pursues this disease?
We will be identifying our needs as we go along, and we have a very close relationship with CDC. In fact, at 5:45 Geneva time, just before coming into this hearing, we were talking with our colleagues at CDC about certain needs that we need as far as technical support to countries. We've also been dealing with internationally with IATA, which is the Federation of Airline Transit Authorities, and they are gearing up to be able to make sure that transmission does not occur on airplanes. And they've assured us that they're taking all measures they can to deal with this disease. So from the U.S., we do need technical support. We are getting it, and we greatly appreciate that.
Thank you, Senator Kennedy.
Thank you very much, Mr. Chairman. And we're reminded again about what a small world community we are when it comes to health care. Your dates of time going back to mid-February, now just about getting into mid-April, over a 2-month period. The steps that have been taken by yourself, the CDC, enormously important, but we see how rapidly that this can spread in a very short period of time and affect families here in the United States. Just quickly, Dr. Heymann, which countries are doing the best things? Could you tell us? Are all the nations doing pretty much following your recommendations? Are we that you know of?
Yes, all countries are following our recommendations, and there's been a great rallying around this outbreak in the 21st century as a new way of working. And I have to say that we didn't anticipate the support that we've had. We only had one Ministry of Health concerned because they were caught off guard. So it's a very it's a solidarity internationally on this, and all countries, including the U.S. and Canada, are following the recommendations of WHO and our experts.
Let me ask you, your life has been studying these kinds of diseases. How does this one rate? How does this figure in the range of different kinds of virulent, either viruses or pathogens that you've studied? Where would you put it in terms of its danger to the mankind?
What's concerning about this disease is that it's a disease which has probably emerged from nature into humans, but instead of having a dead end in humans, in other words, infecting humans and not transmitting on, it continues to transmit through chains of transmission to health workers and then to their family and others. It's not a highly virulent disease. 4% is not a very high case fatality rate. But what is high is the fact that it's killing health workers who are the pillar of our societies. So it is a very important disease because of that. If you look at a disease like Ebola, it kills between 50 and 80% of people, but that disease is so virulent that it doesn't have a chance to spread. This disease has spread very rapidly around the world and continues to transmit from person to person. So it's a disease which may not be high as far as mortality, but it certainly is high as concerns transmission around the world.
Dr. Fauci, do you want to add something to that?
Yes, Senator Kennedy, I agree with Dr. Heymann. We are all concerned, but since it's an evolving epidemic, I think we need to emphasize, because whenever we say concern, some people say, well then, gee, we should be panicking, we should be, what should we be doing that we're not doing? I think that the public health measures that are being taken internationally under the leadership of WHO and internationally and domestically under the leadership of the CDC are right on, and Dr. Gerberding described some of these. So I am concerned for the reasons that Dr. Heymann mentioned, is the transmissibility, the fact that it's a new virus. The point that Dr. Heymann made is an excellent one. When we had the problem with the bird flu a few years ago, and then just most recently the small number this year, it was a type of a flu that is involved with chickens, and it's called an H5N1. And when it jumped from the chicken to the human, it jumped from chicken to human with several cases. We dodged a bullet because it didn't then go from human to human to human. The problem with this one is that it very likely jumped from an animal species to a human, but now it's spreading in humans, and that's the thing that's concerning us all.
Dr. Gerberding, I think most Americans want to know, what can they do to prevent getting it? What would you say to people that are watching this and say, what can I do in order to try and avoid it? What advice would you give them?
Right have indicated that people should avoid non-essential travel to the countries where this is especially problematic, and particularly in community situations. And so we're recommending that unless you have to go, defer your trip and wait until we have a little bit better handle on containment in these regions. If, in the domestic standpoint, we have a very small number of cases of SARS, but if you are a household contact or a healthcare worker, to be alert and use the recommended precautions. Beyond that, I think what people can do right now is be informed. Stay up to date, understand where the epidemic is, understand what's going on in the community, and
Talk to their doctors, get more information.
Exactly.
Do you have websites on this?
Yeah, we I think past.
Maybe you'd mention what you'd suggest to people. Good, give you an opportunity. What to people that are watching or reading about this hearing or watching the hearing, what can they do? Obviously, we'd be interested in telling them about the website, and then calling their public health or their doctors to find out about it.
Absolutely. We have put a high emphasis on trying to get all the information out as quickly as we can. As WHO has something, we turn it around and get it back up. Our website is a very good resource. It's www.cdc.gov, and you can find pretty much all of the guidance, all of the information from WHO, and anything else that would offer advice. We have information there for clinicians, which are clearly very critical in recognizing cases and implementing isolation precautions. I should also mention that just Friday, with WHO and CDC and clinicians in Asia, we were able to do a satellite video conference to educate clinicians and infection control professionals globally about how to recognize and isolate SARS patients. So we got many thousands of people who were able to get that information on the web as well as through the satellite.
As I understand, there's a categories of the communication of various diseases called the R0 value, which you're familiar with. The top is measles, which is 16, and the bottom smallpox, which is 4. Of course, we thought we'd eradicated the smallpox. And then there's polio, which is 5. We've made progress. And then there's SARS. The best estimate is 6, which looks like it's fairly low in terms of the range. But that could be deceiving, could it not? This could, if people didn't have some form of immunity or potentially some other kinds of protections, I imagine, this could go very rapidly through the population. Could you comment on it so
Sure.
that they have an accurate? We don't want to unduly alarm people, but we ought to have the best in terms of science information. What is your
The R0 is a number that tells us how efficiently a disease is being transmitted, and it has to be greater than 1 for an epidemic to propagate. The estimate of 6 is a very preliminary estimate. One of the things that's probably going on with this epidemic is that some patients have an R0 that's quite low. They're not transmitting to very many people at all. And then there may be a few patients for whom the R0 is very large. And so that is kind of confusing the situation in terms of understanding this. We don't want to alarm people unnecessarily, but we do want to express the fact that this is the beginning of a problem. We're learning as we go. It has the potential to spread very quickly, and we've seen that, and it has the potential to spread globally. We've seen that. So we've got to work with our public health agencies and our clinician community to do everything we can to identify and contain cases when they do occur here, and to be alert to where the threats are internationally.
You mentioned it's the beginning of the problem, and I'd ask Dr. Heymann too. Where are we? Are we in the first inning? Are we in the halftime? Are we coming into the
They don't do innings.
Geneva? Dr. Heymann is a good American, understands these. Can you tell us where we are? Someone said of the first lines of an opening scene.
Let me go back to what Dr. Fauci said earlier. When a virus emerges from nature into humans, there are many things it can do. It can emerge, it cannot spread from human to human. It can emerge and spread from human to human, but attenuate or decrease in its power over time. Or it can spread from person to person and continue to spread and become an endemic disease in our population. We're somewhere between the second and the third as far as our understanding of this disease goes, because we've only had a limited time to study it. We're now in the third and fourth generations of people who are infected. We don't know if this virus will continue with its same power to infect others as we go along, or whether it will drop off as time goes on and not be so virulent. We suspect the worst, and we have to be ready for the worst, but we're still between that second part when it transfers from person to person and may be decreasing in virulence over time, and the third when it transfers from person to person and remains a very serious disease. I think probably Dr. Gerberding could supplement that a bit better.
Anything you'd add?
Yeah, it's too early to say is the short answer to your question. We agree with the WHO position that we can be hopeful, but we need to be prepared for the worst case scenario. And actually, we are already looking at our influenza pandemic planning process and seeing if we can translate that plan to make sense for SARS, just in case. And we want to make sure that if that worst case scenario does happen, that we've got the steps in place to deal with it.
My time's just about out. Just final two questions. One is, why did there appear to be more deaths in other countries than there are for the cases that we have had here so far?
The main reason for the low death rate here is probably that we have a much broader case definition in this country. What WHO is reporting under the probable cases are people who have the whole pneumonia. Here we're reporting travelers with fever and respiratory illness, and less than half of them actually have pneumonia. So we're including people who are not as sick to make sure that we know who they are and that we are doing everything we can to contain spread.
I read in your article you said there's a possibility we might get a seasonal, bounce with this. Can you comment about that? Whether you think with coming into the warmer weather, I guess when you have an influenza epidemic, it doesn't necessarily. The seasons don't make much of a difference, but they do if you don't have great. What do you think with this? Do you think there's some possibility that you get to the warmer weather in the summer, it might diminish to some extent?
The other human coronaviruses do have a seasonal pattern. In fact, most respiratory illnesses are seasonal. The problem is that what's the winter months here is the summer months in the southern hemisphere and vice versa. So a seasonal pattern might allow a specific region to get a head start on containment, but that doesn't mean the global problem will quiet down at any particular point.
Just a point. You put out, I guess, your warnings in English and in Spanish. You might take a look at doing the other languages. We have a very significant Chinese population in Boston that we're looking, and their public health in Boston are translating it, but it's taking them some
Yes.
time. And I don't know if you have all of these capacities. I mentioned there's a range of different obvious languages in this country now, and to the extent that could be added, give you one more thing to do.
Well, I appreciate that. The travel card is in many languages, yes. But we recognize the same issue and have put together an Asian community team at CDC this past week to try to do a better job with that. So thank you.
This little card here was enormously important in Massachusetts because we have 2 known cases, potentially 4 cases, but 2 known cases. One an infant, and the doctor, Springfield, Massachusetts, a pediatrician, was able to diagnose it because they had received this kind of warning, and it just goes to show what it means in terms of communication, good communication early on. Thank you.
We will recognize people relative to their time of arrival and like to keep the questions to 7 to 10 minutes if possible. Senator Dodd.
Thank you very much, Mr. Chairman. Let me thank our witnesses, and let me thank you, Dr. Heymann. This is we lost him, huh? I'll have to look up there. That's not Dr. Heymann I'm looking at. He thinks he's Dr. Heymann. But I appreciate it very much, Mr. Chairman. This is rather tremendous technology, and listen to you, Doctor, talk about the ability to communicate globally as a result of internet services and the like, and taking advantage of this technology for us to be able to talk with someone like Dr. Heymann is important. He's back. There you are, Doctor. We lost you for a minute. You're back again. I noticed just to follow with Senator Kennedy's, just looking at the languages, this is not in, I don't see Spanish on here. Was this a particular reason why it was Spanish? I didn't see.
You didn't see Spanish.
Mine has just Korean and Vietnamese, Japanese, traditional Chinese, simplified Chinese. Maybe there are other ones.
We need to take care of that.
It just seemed to me that given the tremendous number of people in the population. Mr. Chairman, I'm going to ask unanimous consent if a statement, opening statement, be included in the record as well. And obviously, the unknown is what we fear. Some of these questions, and I'll ask a question to one of you, but if others want to jump in, please do. One, Dr. Heymann, if I begin with you, are there some lessons that we could be taking? Now, this is early, obviously, and it's only a few weeks here, but it seems to me, given the sort of exponential growth that seems to be occurring with this, and given the point that Dr. Fauci made, and I think you, Doctor, as well, Dr. Gerberding did, about the ability for this to go not only from animal to human, but then jumping from human to human rather easily. At least it appears that way, that we may be looking at a more serious situation here. But the lessons to be learned regarding how different countries' health organizations coordinate. That's my question for you, Dr. Heymann. And will any changes be made as a result of what you've determined already on how the WHO operates? For example, is there anything that could have been done to encourage the Chinese to open up sooner? And to what extent have you been able to determine beyond this particular illness that the Chinese now, given at least the stories I've read about Guangdong province being a province where you have a large concentrations of population on relatively small farms with large concentrations of diverse animal populations, that this has been an area that in the past has produced unique or almost unique viruses. So to what extent are we now going to get future cooperation from the Chinese as a result of this experience?
Well, as you know, WHO has an office in each developing country, and we have an office in China. So what we were able to do was to get in immediately when we found out about the disease in Guangdong into our office, which we reinforced with 2 specialists, one from CDC and one from WHO. Those staff remained, however, in the office and were only after a week allowed to talk with the authorities at the Beijing or China CDC. What we don't have is authority to bypass a state's sovereignty. And this would never be accepted by any of our member countries in a regulation such as the International Health Regulation, because we're not an agency which has the authority to bypass national sovereignty. The only thing we can do, and what we're trying to do with the new international health regulations, is to create such a pressure on countries that they feel the obligation to work with us. And this is what's happened now with China, we believe. There's been an apology, actually, from the Ministry of Health that it was so long in coming on board with WHO and its team. So the only thing we can do is make this international solidarity so that all countries do work together and feel a pressure from other countries if they don't. Now, I know the U.S. was very influential in discussing with the Ministry of Health of China the fact that they should allow a team in. And this, together with what WHO was doing and others, certainly had a role to play in the final opening of China. But we can't force our presence on countries. We have to force our presence only through an international understanding that infectious diseases are a security issue for the whole world and that they know no borders. So hopefully by this lesson, we've made one step forward in our ability to work with countries. I would just add also that for Chinese, which you were speaking about earlier, on the WHO website, all of our documents are in Chinese if the Chinese community needs them immediately. Thank you, Senator.
Well, let me just take it one step further and ask our other panelists to comment. What steps, given the incredible importance of coordinating activities now between the multiple of nations, obviously, that have to help respond to this, what steps do you think we might take? What steps should the United States take? We're a congressional committee here. We're going to want to know what we can do. What role can we play here, if any? There may be a very candid answer, may be none at this juncture. What you're doing is, by just holding a hearing on this matter and bringing some public attention, is more than satisfactory at this juncture, and I accept that answer. If there's some other steps you think we can take, I appreciate, Dr. Heymann, your point about utilizing whatever rhetorical kind of encouragement we can to other countries. But I would find it terribly alarming that as a result of this experience, we did not find a far more higher degree of willingness to participate and contribute. And my mind is already beginning to think of what steps we might take to encourage, be a little bit more emphatic than encouragement for nations to participate. I wonder if you have any specific suggestions that we might consider here as a congressional committee.
I would certainly welcome your ideas as to how this could proceed, because we we only feel that our mandate goes to creating an international environment where all countries feel an obligation to participate in such an event. If there are measures that you could suggest to us that we could try to work out, we would do that, and perhaps CDC and NIH have some ideas of what they would like to see us do in the future. But we're restricted by our 192 member countries and the regulations we have.
Let me ask you, Dr. Fauci, Dr. Gerberding, do you have any suggestions you'd make to us here? Such as, for instance, putting out a health warning to nations that don't share this kind of information. I mean, just as a generic warning to past people who travel, for instance.
I think what's been done thus far is on target for the stage that we're in right now. I think you made the point earlier that since this is a moving target, we need to continue communications among the health agencies, and a very close communication between the Congress and national and international agencies. That's the reason why we welcome this hearing, to make this a good start and maybe the first in several looks at where we're going. You made the point regarding that yellow card. I actually, as a health person, believe, as you made the example, Senator Kennedy, that we're in much better shape now because we actually jumped on that and created a vehicle for people to be able to understand what they need to do if they get symptoms when they come from these countries. I think the recently signed quarantine order that adds SARS to the diseases that are quarantinable was another step in the right direction. So I think we need to just follow this very carefully and make the appropriate moves as things evolve.
Let me, I was curious, this morning one of the major, New York Times ran a lengthy piece on this issue, and I've read a number of articles over the weekend. How do you feel that the news media generally is covering this story? Is it, I'm putting aside the websites. I realize there have been some websites that have been rather alarmist and so forth, but as a mainstream media, television, print, journalism, how well is this story being covered, accurately being covered?
This morning I looked at the CDC clips on SARS, and it's a stack of newspaper reprints about this big. That's more coverage than we had for anthrax. And so I read through the major articles. I didn't have time to read through all of them. And it's very impressive, the quality and the caliber of the reporting that we're seeing. I think people recognize this as an emerging health threat. They're playing it accurately, not overstating the issues, not understating the issues. I think recently the emphasis on the business consequences have helped people prepare and recognize that there will be other collateral damage from this epidemic. But we have worked very hard to try to educate the media and to make ourselves available to them in any way that we can to get this information out. And we're very impressed with what they're doing.
Lastly, let me raise the issue. I've often been told, I believe this is correct, the anecdotal line anyway, that the word for crisis and opportunity in Chinese is the same symbol. And obviously this is at least not a crisis. I don't know if you use the word crisis or yet not, but certainly one that we're paying a lot of attention to. But I wanted to raise, in addition to the WHO question, I asked Dr. Heymann about what could be done to get more than just encouragement and participation. But I wonder in the research area as well, Dr. Fauci, this is a wonderful opportunity in many ways for us to break through some of the resistance that may exist in certain quarters of the world to share the kind of research that is being done at NIH with other leading research institutions around the globe to develop far more coordination and better cooperation than exists today. And maybe it exists to a far greater extent than I'm aware, but if it isn't, how would you respond to that?
Well, I think the degree of cooperation thus far, early on right now, has been quite extraordinary in the very positive sense. I think that if this serves as an example of what can be done, not only with other naturally occurring emerging and re-emerging diseases, but in the event of bioterrorism, this could just have easily been a microbe that was deliberately released. We're not 100% sure that it wasn't, as likely wasn't, but if it were, the mechanisms that got put into place to address this at the level of WHO and its CDC, and our ability to mobilize the research enterprise, I think is a very good example. I mean, I wouldn't say this would be a dry run because it's substantial in and of itself. It's not a dry run for anything. It's real and it's serious, right. But it allows us to be able to show that the apparatus that we have put into place actually can work.
But would you just comment, by the way, Dr. Fauci has said that there's very much satisfied that this was not a bioterrorism in any way. That's been the news reports I've read as well. Dr. Heymann, do you agree with that conclusion? There's no evidence you've seen that this would be anything other than through natural causes, if you will?
There's no evidence at present that this is anything but a naturally occurring infectious diseases. But as Dr. Fauci has said, the mechanisms in place will deal with both a naturally occurring or a deliberately caused infectious disease. And we've actually, as we've been revising the international health regulations, taken that into account. So, no, there's no evidence.
Mr. Chairman, I thank you immensely for holding this hearing. I think it's tremendously worthwhile. And I wonder if we might just keep the record open for a while here for any sort of recommendations from this hearing that these witnesses or others might bring to us as how we might legislatively, if there is such a role for us to respond to this in some way, to encourage greater participation in response to these kind of situations. But I thank you for doing this.
We'll certainly do that, Senator Dodd. Thank you. Senator Sessions.
Thank you, Mr. Chairman, for this hearing. It's a fascinating hearing, and I'm afraid with our highly mobile world, we'll be seeing more of these challenges in the future. Dr. Heymann, you indicated that this has provided an opportunity to try out some of the new procedures I presume that you've adopted. What's your evaluation? How well has it worked?
Well, I had to smile when Dr. Gerberding was telling how many people were working on this from CDC, because in Geneva we're doing this with 29 people, and it's been quite a strain on the systems that we have and on the staff that we've had. But we've had some very devoted staff working 24 hours a day in some instances to pull this off. What we need to do now is to strengthen those systems to make sure that we have the staff available, because this won't come up every day. But when it does come up, it's time intensive, it's people intensive, and we need to make sure that we make the correct changes. We have one person coordinating all the information and doing most of the interviews, a spokesman for WHO. We're very under-equipped to do this type of activity, but we now have the chance to see where our inadequacies lie and how to move ahead faster, because we want to be able to run the international health regulations proactively rather than passively, as has been done in the past.
And I would understand that such a disease as this is not inevitable that it spread, and that the sooner we act and the more vigorously we can act early could limit the danger of a widespread epidemic. Is that correct?
That's correct. We've seen after the alert went out on the 15th of March that countries that had imported cases since then had not the big healthcare worker and other epidemics that countries had before the 15th. Canada was the country which reported on the 14th, which stirred us to the international alert. And since then, countries have been able to deal with this disease very effectively. The only caveat that we don't know yet is whether or not this disease may occur in people who don't have symptoms, whether they're infected and don't have symptoms and are spreading this around the world asymptomatically. That we don't know yet, but we will know that as diagnostic tests become available.
Either one of you would like to comment on the questions I asked Dr. Heymann?
I would just like to agree how important the lessons we've learned from the past have been in making this effort happen as quickly as it has. 2 years ago, I don't think we could have done this, but the investments that have been made in the public health infrastructure and the terrorism preparedness have really paid off. Every time we have an event like an anthrax attack or a West Nile investigation or a SARS outbreak, we also learn and we improve, and I think we have improved tremendously internationally as well as domestically over the last 2 years because of the major improvements in both the CDC's capacity but also the NIH's research capacity and the whole public health infrastructure. So we really thank you for your support and interest.
Dr. Heymann, are you able to call Dr. Fauci and ask for help on research, for example, when something like this emerges?
Yes, we are, and we understand that there is a meeting in the U.S. this week on vaccine development, which we will be following very closely. We're very grateful that the U.S. takes the steps that they do to keep the world on the cutting edge of new diseases.
Dr. Fauci, so you work with other agencies and provide the research capability that may be needed to identify precisely what the disease is and how to fight it?
Yes, Senator Sessions. It's actually an ongoing collaborative effort. The WHO, in fact, David visited me in my office some months ago talking about the interaction between WHO and emerging and re-emerging diseases. We didn't have any idea at the time that this would come up so soon thereafter. The work that the CDC has done in jumping on this so rapidly and getting the proposed virus, which we feel reasonably sure is the virus, to not only isolating it, but getting it into the broader research enterprise so that we can do the kinds of vaccine therapy and other work, I think is an excellent example of how the research enterprise seamlessly goes back and forth with the public health enterprise. It shouldn't be looked upon as two separate issues. There's the public health and then there's the research. They really are seamless. And there's some public health aspects of the research and some research aspects of the public health.
I agree with that so much, and I think we need to do a better job in government of making sure our various agencies work together. We see it in the Defense Department. They're doing a lot better. We see it in Homeland Security. They're going to be working closer together, and it needs to be done here. Dr. Fauci, to what extent are you able to positively identify this virus? If a child in Massachusetts, the physician believes they may have it, is it diagnosed by symptoms or is it diagnosed in the laboratory?
Well, I'll just make one statement and then hand it over to Dr. Gerberding because they're working on a diagnostic test. Right now, it's a syndromic diagnosis. Someone comes in with the fever, the typical physical findings, signs and symptoms with an epidemiological link to an exposure. That person is considered to have the syndrome. As we now having the capabilities of isolating and identifying with diagnostic probes, not only the virus, but a response to the virus, that diagnosis will be much more definitive. But that's exactly what the CDC is working on right now.
Dr. Gerberding?
Thank you. We have 3 tests that can be used to identify infection with coronavirus. The test that looks for the piece of the virus RNA in the patient's tissue specimens would help us diagnose cases early while the infection is still ongoing, and we are creating the primers for the molecular tests that need to go out to our laboratory research network and make that test available in public health laboratories. So we've got to make the reagents, and then we've got to teach people how to do the test, although they already know how to do this technology. The other 2 tests are based on antibodies that develop once you're infected. And the problem with that test is that when you first get sick, the test will be negative because your body hasn't had enough time to make an antibody. And so we have to collect serum 3 weeks later after the onset of illness and see that the test is positive. So it's helpful in saying, yes, this was a case of SARS, but it's not helpful up front in knowing who has it and who doesn't, or who needs to be isolated or who doesn't. So we're going to be working with FDA to get these tests into a form where they would be useful diagnostically in individual patients. Right now, they're primarily a tool for determining where are the cases and what can we learn about spread and how effective our containment methods are. And I'll just say that the fact that this has happened in just a weeks period of time, really 2 weeks since we've had the virus and begun to work on it, are we able to do this kind of diagnostic testing is an unbelievable achievement in science, and it wouldn't, again, have happened without the 11 international laboratories that WHO has put into this collaborating network. These people have a daily conference call, they have a secure website, and they truly are exchanging information in real time. So we've been able to accelerate the whole process of virus discovery and testing.
And if someone does contract the virus, what can you tell us about the normal treatment process? How often and how long might they expect to be in the hospital? And what kind of costs would that present the United States, for example, if it became a widespread as a flu epidemic?
The data we have right now suggests that there's a spectrum of illness associated with this virus, and it's possible that some people have very mild infections that would not normally require health care, although they could pose a risk of transmission to others. The people who get the pneumonia often are quite ill and require hospitalization and, in some cases, mechanical ventilation. Those are, of course, the people who have the most serious illness and are most likely to die from the infection. But the majority of people do recover. Unfortunately, sometimes it takes many days to a few weeks to really get back to baseline. And some of the people who've been the sickest are improving, but they're still not back to the way they were before they got ill. So full recovery is possible, and we hope that ultimately will be the case for everyone, but it can be a long time in coming.
In terms of prevention, prevention is certainly the best policy, financially as well as health care wise, I'm sure. Dr. Heymann, we had a very interesting hearing here last week with Dr. Gisselquist, who did a study on the transmission of AIDS in Africa, a very provocative proposal that suggests that WHO's numbers from healthcare transmissions, that is by needles and injections, and HHS's numbers were below what he thinks the studies show. Have you had a chance to personally look at that, and would you give it a study? Because it would make, I think, a significant difference if he were even partially correct in how we deal with the transmission of AIDS in Africa.
In the 1990s, we did studies in Uganda and in Zimbabwe, which showed that transmission to midwives, nurse midwives, and others was important, and some of the variables, some of the reasons were because they stuck their finger with needles as they were doing procedures. From the evidence that we have, though, in Africa, the majority of transmission is sexual transmission, and that has remained constant throughout the studies that have been done. It's a sexually transmitted disease first and foremost, which does affect all persons, and then is transmitted, unfortunately, from pregnant women to their children in many instances.
Well,
But there is also transmission by needle and syringe as well.
I hope you would just take a look at that new study. And I would.
We have looked.
Good.
Thank you, Senator Sessions. We'll do a second round here if people wish to. Can you tell us, Dr. Heymann, whether China has adequately quarantined Guangdong province and Hong Kong, or whether they need to do more?
It seems that Guangdong was the source of infection for Hong Kong. Right now, on people who are leaving Guangdong by train or by airplane, they're given a card with the symptoms of the disease, and they're told that they should see a health worker if they have that disease. There's not much more that can be done at present in there except cordoning the area off. We've done that internationally by asking travelers not to travel to that area if it's not necessary, voluntarily, because we don't understand enough about the disease. We feel that China is taking the measures now that they can. If these measures had been taken in November, perhaps the disease would not have spread.
Do you, just generally, what is the death rate that they're experiencing in China from people that have been infected? Do you know?
The death rate in China is the same as it is in other countries, between 3.5 and 4% of all people who are infected.
Dr. Fauci, where do we stand with the vaccine effort, developing a vaccine? Obviously, it takes a long time to develop a vaccine, but you were, as you said, phenomenally quick in developing identifier capability, diagnostics. And I'm wondering, first, what do you see as a time frame for a potential vaccine? What is the problems with developing a vaccine? Do we have enough of a vaccine industry to do it in the United States? An old issue, an issue which we are going to be revisiting later this week. And thirdly, do we expect this to mutate? You mentioned that this may, because of its structure, mutate into a more difficult, even more difficult disease to deal with.
Okay. With regard to vaccine effort, Senator, for this particular virus, as you know, vaccines take years and years, and there are generally generations of vaccine. The point that I made briefly in my opening statement is that the good news about this is that the microbe is growing in a cell line. It's culturable, so you can get enough of it if you rev it up and scale it up to do what would be like a first generation of a vaccine, namely just take it, kill it, go in an animal model and see if you vaccinate the animal and then challenge the animal, first a mouse, then a monkey, and show what we call proof of concept, that you can actually protect some species against this with a vaccine. Yeah. If we talk about that, that will likely, if we're lucky, take several months to do that. To get that then translated into a first-generation vaccine for humans will without a doubt take longer than a year. I don't think there's any chance that we're going to have a vaccine this time next year, likely within a period a bit longer than a year. And that's if we're lucky. But that's not going to be 10 years. And the reason we say that is the concept that A, it's growing, B, there are coronavirus vaccines that have been successful in animal. Now, when I say vaccine, and I'll get to your second question, that doesn't mean necessarily we'll have enough of it to give to everyone, but we would be able to at least get into some human trials within a period a little bit greater than a year. The success of showing that that candidate is a usable virus for distribution, I cannot predict how long that will take. With regard to industry, this is another example of what we had discussed several times, is the importance of getting industry involved early, because we can do those first steps. We can even take it to the point of pre-advanced development, but when you get to the point of advanced development in a vaccine, you need the interested industry involved, because the killed vaccine that I mentioned is just the first generation. There's the vector type vaccines, the DNA vaccines, and then the possibility of a live attenuated vaccines, each of which have the potential for a greater degree of efficacy. So it's a process that you'd have to measure over years. The final question that you mentioned about mutating, coronaviruses are RNA viruses. They have a very bad, what we call proofreading mechanism when they replicate. So they have the possibility of naturally being very heterogeneous and variable. Is it possible that this vaccine that's now in the community, this virus that's in the community will mutate some more? Sure, there is a possibility, and very likely that it'll mutate. Will it mutate to the point where it changes any of the relevant functions that are going on right now? Unlikely, because it usually takes a longer period of time interacting among different men, women in the society before you start seeing mutations that are clinically relevant. So I think ultimately there's the possibility, given the nature of the virus, to ultimately start mutating. But at this early stage of its jumping into humans, it would have to be a little bit more adapted before you functionally mutate to the point of having a difference.
Thank you. Just shows we need to pass that Dodd-Frist vaccine bill.
I think he calls it Frist-Dodd, but I appreciate your point.
Senator Kennedy.
Let me ask you, Dr. Gerberding, what are the symptoms? We've tried in the earlier round to ask you what people might be able to do, but what would you say? Could you tell us about the symptoms of the people that are watching or hearing this? How is this different from sort of the flu?
Well, the short answer is that it doesn't differ very much from the flu. It's pretty much the typical viral-like illness when it starts. We have a hint that it kind of has a biphasic pattern. So you
want to just describe that again a little? I think most of us know what the flu is about, but just so that we people be reminded about it.
Not everyone starts off with a fever, but they usually feel tired, they have muscle aches, may have a sore throat, and then usually a fever develops. Sometimes headache is a prominent feature. In a few people, they have that early illness and then the fever goes away, and then that's followed by coughing and sort of the pneumonia type symptoms of the chest pain, the tightness, progressing to the trouble breathing. But in the very earliest days, it looks like any other kind of common cold or common viral illness. And what you have to know is that you've been either a traveler or you've been exposed, and if you have those very early symptoms, you need to contact your healthcare professional.
And at least the best treatment now, what would you, what does the you'd say, either Dr. Gerberding, what are the best treatments now for that?
There are non-specific treatments, which particularly for the people who have pneumonia include making sure that they're hydrated, that they've got good nutrition, good nursing care, and so forth. But because at the beginning we often can't tell it apart from other common causes of pneumonia, many patients will need to be on antibiotics in case we're wrong, it's not SARS, it's regular old pneumococcal pneumonia or something. Some patients have been treated with anti-flu, antiviral medications. In terms of specific treatment for SARS or for coronavirus or for other viruses per se, there isn't any. Many clinicians globally have tried ribavirin. The results aren't in, but I don't think it looks real promising right now for that to be a solution. Some other things have been tried, and it's just anecdotal and far too soon. We do have already an investigational new drug protocol developed to look at ribavirin treatment more systematically to see if it is offering anything. And the results of the work that's going on in screening antiviral drugs will help guide future protocols. So I think we'll have things to try in the future, but right now we don't have much on the shelf that makes sense.
We had Dr. Fauci talked about the vaccine. What about the diagnostic test? That can be developed much earlier. Can you tell us what when you think that might be available?
Well, last week we distributed the first test results to state health departments with case patients in the United States. We can't sensibly give test results until we have that second day 21 sample, and since so many of our cases are just now coming into that epidemiology curve, it's too soon to interpret anything, especially the negatives at this point in time. But we expect over the next couple of weeks that we will be getting at least some of the test reagents out broadly.
So, I mean, that's very encouraging and should be to all of the public health that these kinds of tests are going to be out and available in a very early period of time. It'll be enormously valuable and helpful to them, I would expect.
We're hoping that will prove to be the case. Of course, we have to test uninfected people, and we have to test really very sick people, and then the kind of mixed picture in between to really know how sensitive is the tests, are these tests, how specific are these tests, and overall, you know, what does a specific test mean in a given individual? And that's where I think FDA will help us go through the process of really validating this for individual patient use.
And they're obviously working with you now.
Absolutely. Actually, Secretary Thompson has pulled together a departmental working group on this with NIH and FDA and CDC, and we're all part of a team pulling together the reagent development as well as the vaccine product development.
Let me ask Dr. Heymann, are other countries working on either the diagnostic tests or the vaccines? We obviously are. Are other countries, and can you tell us where they might be?
On the diagnostic tests are being developed in Hong Kong. Singapore is working on some different tests, as are laboratories in Germany and also in other laboratories around the world. So in these 11 laboratories that are collaborating, they're also working. The beauty is that they're exchanging their information so that they're getting results faster.
And vaccines, anything going on in Europe this time, or any of the other?
The only thing with vaccine at this point is in the United States, as far as we know.
Just finally, there's really no difference, Dr. Fauci, in the coronavirus. This is, you believe, to be a coronavirus. In the early time, there was some question whether it might be or might not be, but you believe, because that's obviously basic in terms of developing the vaccine,
Right.
You believe that the science to date is that's what it is.
The virus that the CDC and others have isolated is unquestionably a coronavirus.
Okay.
The evidence absolutely 100% that this is causing it is almost there, but
Okay.
not 100% yet. But we're assuming it is. All the work that I described is I'm confident enough to make the investment to go ahead with the
That's
research
good.
that's assuming this.
Well, that's reassuring. And
Right.
I think, finally, can you tell us what the president signed, the executive order on quarantine? What's that going to mean to people? Can you explain it to us and to the American people? What that might mean? Somebody coming back from China, they've been in this area what are their chances if they're getting in quarantine? What will this mean to them, and how widely do you anticipate that this might be used?
Well, first of all, right now we're not quarantining anyone in the United States, and we're not planning to quarantine anyone given what we're seeing right now. What the executive order does, it gives the authority to quarantine for SARS in the same way that we can quarantine for other communicable diseases like cholera already. So it's just simply a matter of adding SARS to a list of diseases that already, if necessary, we can take action to prevent spread within the community. So it is a precaution, a just-in-case kind of executive order.
I want to thank you all. This has been enormously interesting, very helpful. And I must say, Mr. Chairman, I think it's very reassuring for the American people. This is, as Dr. Gerberding had pointed out, the list on the articles that are about it. It's an enormous concern. It is in my state. It is all across this country. And I think the reassurance that American people should have with the fact that we have been on this so quickly with the leadership of the World Health Organization, the NIH already moving with the vaccines, Dr. Gerberding, and the communication and working with public health groups. It's American people ought to understand that this is a danger, but that our leading health research agencies, including the FDA, are working on this, and we have really the best in the world that are working on it, and there are going to be others who probably will be infected, and some will lose their lives, but I think American people should be very reassured that we've got the best working on it and dealing with it in an important scientific way, and help is on its way. I thank you, Mr. Chairman.
That's a very salient comment. Senator Dodd, do you have any additional questions?
Just a couple of brief ones. I think just to follow up on that point, it's always the unknown that's always the most frightening, and so by sharing with us your thoughts here today, that does a great deal. Just a couple of quick questions. We had at least a suspected case in Connecticut at the University of Connecticut, a student, and it occurred to me reading the articles again today because they're following up with that. We received a tremendous number of calls from other universities just to know how the university handled that particular case. How difficult is it to identify this based on the coronavirus a cell you had up here with a crowning effect and so forth? Why is it is it that hard to identify in people? Why are there a number of suspected cases? How does that differ from the known cases? What are the numbers like here? And is there a great differential between suspected cases and known cases?
In the United States, we have decided to lump everybody together in the suspected case under investigation category because we think that's the best way to help contain spread from even the less suspicious individuals. The reason that we can't get a picture like that for every patient is that picture came from an electron microscope, and it's very difficult to get virus out of tissue through non-invasive strategies. So if we could do a lung biopsy on everyone early in illness, we'd probably be able to find this virus. But we can't do that, and so mostly we've had to rely on autopsy tissues, and fortunately we haven't had a lot of those to deal with. So we can see the virus in tissue, but not very often.
And well, then that makes the problem that much more difficult in a sense then.
That's why we're relying on these indirect tests like the antibody tests. If someone has a negative test when they come in and their antibody test becomes positive, it's really strong evidence that they've been infected with this agent. And we know that the tests are looking very specific, meaning that we've tested them on 300 or so people with no illness related to SARS, and the test is always negative in those people. So when we see it coming up in the course of illness, that's a really strong clue of causality. And we're just looking at more people to make sure we can say that with reliability across the board.
And is the treatment that the question Senator Kennedy raised about what are you doing at this point with people who you suspect have SARS? Is the providing some sort of treatment here in any way producing its own set of problems in any of these patients at all that you've been able to identify?
It is important to appreciate that when people are sick with pneumonia in hospitals, particularly if they're on a mechanical ventilator, lots of other complications can develop in addition to the damage that the virus is causing per se. And one of the reasons why we're very cautious about recommending treatment when we have no idea whether it's useful is that there are side effects. For example, there are side effects of ribavirin that can be very serious, such as anemia and other complications. So we want to do that in a very careful way so that we protect the patients from the harmful effects of what would really be experimental treatment at this point.
Do you have any idea what the gestation period is between exposure and coming out with the symptoms? Based on, again, a limited number, and Dr. Heymann, jump in here too if you've got some additional information, but what are we looking at here between exposure and actually getting symptoms? Do you have any idea of that at all?
It's been difficult to say in specific individual cases. Right now we're operating under the assumption it's somewhere between 2 and 10 days, but recently there have been a couple of anecdotal reports that suggest maybe the incubation period could be a day or two longer than that.
Right. And is there any patterns developing here about age and so forth? I've read where it seems as though you see in some of the cases of fatalities, it was older patients, although I then saw some information that said even very young patients. I wonder if there's anything emerging here that would show at this point that you'd feel confident enough to share with us in terms of some conclusions. Again, I understand that you want to be careful, but I wonder if anything that you've been able to discern at this point leads you to a particular set of conclusions about this. Right now,
the data suggests that the most common age of acquiring this infection is sort of middle age, like around age 50. And men and women seem to be more or less equally affected, although in healthcare settings where there are more women healthcare workers, there will be potentially more women cases in those settings. And I think Dr. Heymann probably can give you the global picture on how that pans out.
How's that doing, Dr. Heymann, just quickly on this?
In Singapore, there are now 3 children who have the disease. But now that we have access to the Chinese data, which is 4 months worth of data, we'll rapidly know whether or not this disease did remain in adults who were the first infected because they're health workers, or if it does also occur in children. We believe it does because it spreads from parents to their children, the parents being health workers, and then we don't know what happens in the community after that. But we believe we will know after we've finally been able to analyze all the Chinese data.
And how much follow-up is occurring with those who have apparently emerged, having, let's assume, suspected and even had SARS, have then apparently been able to recover fairly quickly from it, following those people afterwards to determine to stick with them? It seems to me that their immune system or something about their genetic makeup would be worthwhile to know. Are we following up? Are we doing that?
Yeah, at CDC we have something called Team B, which is a group of people we've asked to step aside from being involved in this day-to-day and to think about the kinds of questions that you're bringing up so that we know that we're asking and being prepared to answer these scientific questions. So we're creating a protocol for the long-term follow-up of people after SARS. Simple things we need to know. Do they still have the virus? You know, is there a carrier state?
Right.
Why do some people get sick and some people don't get sick? How long does it take for full recovery? How many people don't have full recovery? There's a lot to learn as we go forward. And
2 last questions. One is, you talked about the group that's organizing here. What about the companies themselves? It seems to me the pharmaceutical industry, to what extent are you involving them in their research activities of what you're doing so that they're very much a part of this collaborative effort?
You know, we are reaching out to the pharmaceutical industry in the arenas of not only vaccines, but also in therapeutics, asking them if they have compounds on their shelf, some of which are just screen compounds, or some of which might mechanistically have a possibility of blocking the virus. So right from the get-go, we made it very clear in our interactions with industry that we're willing and want to very much outreach with them in the areas of vaccines, therapeutics, and also diagnostics.
Is that unique in this regard because of this set of circumstances? Is this normally something you would do with a similar kind of situation, other similar situations, obviously a little different than this, but or is this something you'd be doing that's fairly unique in that regard?
No, I wouldn't say it's unique, Senator, but I would say that over the past few years, particularly in the activity that has now evolved vis-a-vis the need for pharma as well as biotech companies in the development of countermeasures for biodefense has kind of shook the ground a bit, that we really do need to have a good collaboration between industry and academia and federal and international organizations. So although we have done that in the past, the fact that it's happening now so quickly, I think, is a testimony to the realization that no one can really do it alone. We do need industry
I
there.
understand that. And I wonder if there are some problems, and you may not be able to answer this right now, just with regard to proprietary information and the unwillingness of companies to become that, if they're sharing the kind of information that they might feel could end up in a public domain in some way. Is that a problem?
Well, that sometimes is a problem, but that's a problem not only with companies. We just have to deal with it.
And lastly, let me ask you this. If you're looking at this situation, again, everything you've said here, that the important thing about this hearing, I think, additional to this specific information, is that the worst thing that could happen right now is for a panic or an alarmist situation to take over. But I just want to have a degree of confidence in light of the fact that this may become a more serious problem. Are you planning on steps, Doctor, that to take if this thing emerges over the next number of weeks? We found an exponential growth. Are you thinking ahead?
Yeah, we absolutely are thinking ahead. The kinds of things that Dr. Fauci's been talking about in terms of antivirals or vaccines are way down the road, and so we've got to be prepared to do what we can do now. Detection is critical, and we have made major investments in detection for terrorism, but we are scaling those up. Getting the tests out so we know who's got it and who doesn't. That's a very high priority for us. If we see ongoing spread, for example, if we get into a situation like Canada, where there is widespread transmission within a hospital, we will act quickly to close the hospitals to new admissions and cohort the healthcare workers and patients, because we know what will happen if we don't. We've learned by watching the experience elsewhere. And similarly, if we saw a situation where there was a danger to a school or some other kind of scenario, we would take what is, I think, very sensible guidance right now, and we will add steps to help people avoid transmitting to others while they're sick. So there is more we can do if we need to.
And do you have enough resources at this juncture looking ahead, do you think, to handle all of that and personnel?
Right now, I think we're right on target.
And Dr. Heymann, just curious whether or not you and the World Health Organization, you mentioned 29 people, should this grow to be a more serious problem, do you have adequate personnel, resources, and so forth to be able to handle this?
Yes, our Director General has agreed that she will shift resources to this should we need them. So we're in the process of looking how we can shift our budget to deal with this problem and to keep the people and the staff that we need. What we also depend on is people coming in from other agencies or other countries, and CDC again has helped us in that respect in detailing people to WHO to work on specific issues with this outbreak.
Thank you. Thanks, John.
Thank you very much, Senator Dodd. And once again, on behalf of myself and the committee, and I know Senator Kennedy, we certainly appreciate you taking the time to come here. We want to thank you, Dr. Heymann, for taking your time late in the afternoon or maybe early evening in Geneva and giving us the time you have. And we especially want to thank the World Health Organization for the extraordinary job you've done on this threat to the world health, to the world community generally. Dr. Fauci, NIH always does a great job, and Dr. Gerberding, same with CDC. We appreciate the fact that you're so expert and that you give us the confidence that, as Senator Kennedy said, here in the United States we have a health community which is on top of the issue and is aggressively pursuing the protections America needs. So thank you, and
Thank you.
appreciate your time.
You're watching Public Affairs programming on C-SPAN 2. Coming up in about 15 minutes, we'll bring you today's Defense Department briefing with Defense Secretary Donald Rumsfeld. We'll have that for you live beginning at about 2 o'clock. Until that time, a segment from this morning's Washington Journal with author Johanna Newman. She joined us to talk about her book on the media's coverage of the war. The book is called Lights,